topics and opinions expressed in the following show are solely those of the hosts and their guests and not those of W4CY Radio, its employees, or affiliates. We make no recommendations or endorsements for radio show programs, services, or products mentioned on air or on our web. No liability, explicit or implied, shall be extended to W4CY Radio or its employees or affiliates. Any questions or comments should be directed to those show hosts. Thank you for choosing W4CY Radio.
Welcome to the Ask the Expert show on W4CY Radio and Talk4 TV, where we bring you educational information from top local experts in the fields of legal, health, financial, and home improvement. Now sit back and listen to experts in family law, association law, hearing loss, business brokers, home care, along with many other topics. Now here are your hosts, Steve-O and Sophia.
Hey, good afternoon, Houston. Welcome to another Ask the Expert show where we bring you the top experts in the field of legal, health, financial, and home improvement. You know, we do about 35 shows a month all across the country. This show here is one of my favorite because we're talking sleep apnea, stop snoring. And boy, I got to tell you, I have been on a CPAP machine for probably the last 7 years. It was the best decision I ever made. We were lucky enough to get, I'm telling you, the top expert, not just in Houston, probably throughout Texas. Let me introduce you to Dr. James Ludwig. Hey, buddy.
Hey, how are you?
Doing good. No hat today.
Let me turn on the light. Yeah. It's 101 degrees here, man.
Oh, God.
I need a hat, but not that kind of hat.
I hear you. Listen, I am so glad that we do this show because I know what it's like to have sleep apnea. And we're going to talk about those things today. But what the biggest thing I want to get through with this show is you got to get it treated. Don't do what I do and let it go. And we have got the finest doctor in Houston. We're going to be talking about sleep apnea. Hey, James, tell people about your practice.
Well, I'm a solo practitioner. Opened my practice in 2006. I trained at Baylor in Houston, and then I did a fellowship in sleep medicine. So I'm an ENT that's also fellowship trained in sleep medicine, and we treat general ENT, sleep, sinus, congestion, allergies. We dispense CPAP equipment. We fabricate oral appliances, police dispense them. We do sleep surgeries, we being eye. So we offer a comprehensive options for treating sleep apnea instead of just a one-all for fit or one fit for everybody. And I think that's real important to have that experience with different options, because if you don't have experience with different options, it's hard to help people navigate their ultimate treatment choice.
Talking from a person who suffered with sleep apnea, I think one of the great things about your practice is if you go to a dentist, they're going to want you to be on an appliance. When you go to see James, you've got so many different ways that you can treat sleep apnea. But the first thing is, how does someone know if they have sleep apnea?
Well, usually snoring is a big one, because snoring is the first sign, that your airway isn't staying as open as it does when you're awake. That's why you only snore when you're asleep. And then it can be how you feel. You can feel tired or wake up, unrefreshed, or just be dragging all day. And a lot of people that have those symptoms, they often, especially men in their 40s or 50s, they think it's testosterone, so they go get their testosterone level checked and probably even put on replacement often. For women, a lot of times they get their thyroid checked, and because they think it's thyroid, they're low on their thyroid hormone, which they may be, or other hormones. And then oftentimes the bed partner tells the person they're not breathing, or just the snoring so loud that it's bothering. I mean, I have a lot of people, you'd be surprised how many husbands and wives don't sleep in the same bed. You
Oh,
kind of
I
just assume everyone
understand.
that's in the same bed, but I'm learning that there are a lot of two masters in bed in houses these days, or at least a pseudo second master. And it's not something people come out and just advertise. But and another way is if you have some kind of minor procedure that requires sedation, and then whoever sedates you, either your oral surgeon, your gastroenterologist, or anesthesiologist, um, they'll notice that you're having a problem under those conditions. Maintaining your airway. So there's lots of different ways people figure it out, but eventually they figure it out. Unfortunately, they don't usually figure it out for several years after they've been dealing with it, because it does happen when you're unconscious. So you don't really know what's going on. It's actually hard for people to even tangibly understand what sleep apnea is. That's why today I thought we would look at some real sleep studies that we do. These are home sleep tests, but the one I use has a lot of good data to look at. And I have a few examples, one with someone who just snores primarily, someone that has positional sleep apnea, then another guy who's like dying of sleep apnea. So I have all three examples, and the reports
Is
that
there
go
a
with
big
them.
difference, James?
Yeah, you're going to show you the big difference. There's a huge difference in these different studies. So I think it'll help people understand what we're talking about when we say you have mild sleep apnea or severe sleep apnea or positional sleep apnea. It's pretty amazing, honestly, to believe this is actually happening to people when they're unconscious. So, and then we can field questions, or I have some patient, case study type stuff. People I've seen this last week or two, I thought was interesting as well. I wanted to present. If that sounds good to you.
Yes.
Okay. So
Anything
do you
you
want to?
do, I'm going to be interested in.
Okay, so let me do this. I'm gonna open this window. Hopefully, can you see my window that I'm showing you? Can you see the screen?
It's coming up. There it is.
Okay. So this first one, this is a patient I saw that actually I saw him mainly for sinus issues, but he does snore some, and we fixed his nose, and he's breathing great through his nose, but he was still snoring a little bit, and he just wanted to make sure that he didn't have sleep apnea. So we did a sleep study. And this is the report that you get when you do a sleep study, and it tells you, how long you were observed. This study was for over 500 minutes of time, and then in the summary here, it tells you on average per hour if you're having airflow issues. And this number of 2 means that on average over this 500 minutes, which is what's 8 hours. That this almost 9 hours, this person had, 2 airway issues or breathing, flow issues per hour during that period of observation. So any number less than 5 is considered acceptable. So in essence, this is what someone would say, oh, I had a sleep study and it was negative. Well, it's negative in the sense that it doesn't have a clinically significant amount of sleep apnea, but you can still have some events, but those events are so infrequent that it's not clinically relevant. Okay, and then
This is after
this
you
is
fixed his nose.
this is after we did got his nose tuned up, and then you'll see this is a graph, and on this graph you'll see the clock on the bottom, 10 p.m. to almost 8 a.m. And then the POS is position, so S is when he's on his back, and left is L, and R is right. And then you see these little vertical lines, these pink, and they're different colors. And these are where the device detected airflow issues. And then this teal line up here is the oxygen saturation. So there's a red light, a pulse oximeter on your finger when you do this particular study, and it's measuring real time how much oxygen's in your blood. And when you're breathing well and your lungs are in good condition and you're in a normal room with a normal amount of oxygen in it, this should be running in the mid to upper 90s. And you can see how nice and stable it is. There's some areas where it's a little bit variable, but that variability can be due to sleep stage, not breathing problems. So anyway, you had a sleep test, and I'm going to pull that up for you now. And
This
this
is
is
all
his
done
sleep.
at home now, right?
Yeah, this sleep data I'm showing you is done at home. And I don't think many doctors take the time to show their patients this actual data that you get. They just show them that report. No one really gets to,
Right.
the privilege of seeing this. But this is just a summary graph like the other one I showed you. And then if we go here, you'll see the clock at the top. See, this is real life. This is 10:25 p.m., 10:30 p.m. So each hash is a minute, 10:31, 10:32, 10:33, and so on and so forth. And we can go anywhere we want. We can go to here, we can click anywhere we want on this, and it will take us right to that period of the night. So if we just click on like right here, and then we go, this is going to be around 12:45 a.m. And then you can see the P flow. This is the airflow. So this is a 4 minutes of real life. From one edge of this tracing to the other edge is 4 minutes of real life. And each deflection is a breath. So you breathe in, the pen goes up, you exhale, the pen goes down. You breathe in, your pen goes up, you breathe out. And you can see, look how nice and regular this breathing is, right? All these hills are all the same size and shape. And then you see the snore channel. He does have a little bit of snoring. So again, people ask me, is snoring sleep apnea? No, here's snoring with good breathing. His oxygen, which is right here, this teal number, is 95, 96. And look how nice his pulse is, 54, 55, I mean, this is a very healthy individual. So you can see that this is not sleep apnea. We can drive through the night here and just look, but if he moves around or something, you'll see like a little bigger breath or something. But this is a negative sleep study. See right here, there's a little bit of he probably moved or something there. So this is what normal sleep should look like. So when people say you stop breathing or gasping and stuff, that's not normal. All right, so now I want to show you this other lady, super nice lady that I take care of. And I'm going to show you her report, which is here. And this is this test that she had done. Again, she was observed for 500 minutes. And then notice this number, this REI. This is her average. She's having 20 obstructions per hour on average throughout the night. And her oxygen is dropping into the 80s instead of staying up in the mid 90s like the last patient I showed you. And if I show you the graph, it's very interesting. You see the position here, and ours, here's the clock again, 11:42 p.m. And then over to the end of the night was 8 a.m. And then this is position. R is right side, S is back, right, back, so on and so forth. And notice, like, look at this, look at the lines. There's no lines from 11 until 1:30, and then all of a sudden it's like a switch, and they're just one after another. Isn't that interesting? And then just like the switch, it turns off again. And if you notice the position, right, nothing. Supine, which is back, tons of problems. Right, almost nothing. On your back, tons of problems. Left, few problems. Do you see what I'm saying? So she has what's called positional sleep apnea. Like literally your position that you sleep in can cause some people to have tons of airway obstructions. And if you look at the graph of her oxygen, you can see when she's obstructing, the oxygen goes up and down. So let's check out her study. It's pretty cool. So we come over here, and I'm just going to select an area where she's on her side, and let's look at the breathing. So this is her breathing. And the same thing, you can see that her airflow looks pretty boring. If we just drive along, 12:35, we're just going through the night. This is real time, breath after breath after breath. I mean, she's snoring, but the airflow looks pretty regular. You see that?
Yes.
Then if we go to when she flips on her back and look at the same data, I mean, look at this. Breathing, no breathing, breathing, no breathing, breathing, no breathing, breathing. I mean, it's just like one, after another. So
this is the back versus the
side.
Sleeping on your stomach?
This is, no, side versus back. So this is her on her back. And earlier I showed you her on her side.
Wow.
So, can position make a difference? It can. It doesn't mean it will. It doesn't mean it for everybody, but because people say, well, can I just get a different bed or sleep on a Craftmatic bed or sleep on my side? It might work for you or it might not. It just depends on. But it was interesting, if you look at the snore channel, notice when the person isn't moving air, the snore channel is silent because you can't have snoring if you're not breathing.
Right.
Then notice how big these breaths are. So what happens when people have obstructive events is they get really shallow. And then if you remember her baseline breathing, she had nice, kind of like over on the left side here. And then look how big these are, because in order to fix your obstruction, you come out of sleep. You may not know it, but you have these microarousals, and you tend to take bigger breaths, and then you'll notice her heart rate. I mean, it's 81 here, and then she's 87, then it's 80, 79, then it's 84, and it's very irregular, and the oxygen is going up and down, 94, 91, 93, and so on. So this is how sleep apnea harms you. Here she is, you can guess, she's not on her back right here.
James, is there a difference? Is there a difference if you elevate, if you're laying on your back, but your head is elevated? Does it make a difference?
It could, but I don't think it's going to solve this problem.
Right.
I mean, so her study, her report says that she has 20 per hour, but you see, it's kind of deceitful because really what she has is nothing per hour. And then she has 60 or something per hour,
Right.
And then the average, of course, it's like getting an A and 2 E's, and then an A and 2 E's, and then saying your average is a C, Well, you're getting A's and E's. There really are no C's in the study. She's either an A or she's an E. There's no C. But the average of all of this is a C. So that's why it's important, to look at the tracing and to look at, the graph and the positional data, because you can get these kind of little, glean these little tokens of information to help patients. I mean, maybe this person can't use a CPAP machine, but maybe she can just stay on her side and be almost perfect or be much, much better. That alone could be a treatment option, just positional therapy. It's not easy to stay on your side, but yet, it's reasonable to try that as an option. And then this last patient
just asked if you discover you have sleep apnea, can you still not snore?
I don't know what that means.
I guess
can you still, in other words, can you have sleep apnea but not snore?
Yeah, in other words, if someone comes in and you diagnose them with sleep apnea, but they don't snore, does that ever happen?
There's, no. Unless you have central sleep apnea, which is a subset, which is like mainly patients who have like heart failure and things like that. But if you have obstructive sleep apnea, you're going to snore because snoring is the first thing that happens when your airway is getting smaller. Before you have an obstruction, you're going to snore first. So it doesn't have to be loud. It doesn't have to be 10 out of 10, shake the wall snoring, but you're going to have some snoring.
Hey, James, why do you talk to your patients? And I'm curious to know, what do people tell you why they waited so long to come see you?
Well, I mean, there's what they tell you and maybe the real reason. And, I don't know if those are always the same, but, like I said, a lot of people, they put their health kind of down the ladder of things. I mean, if you're not in pain and you're not dying of cancer,
right?
Do you know what I mean? Then you tend just to pretend it doesn't exist or it's not important. I mean, it's not free to see the doctor, and then it takes time out of your day. And again, if you're not suffering, to the nth degree, I think I do it. I think everyone does it. You just keep kicking the can because you don't really know how much it impacts your quality of life until you get rid of it. So you're kind of ignorant to the fact that it's impacting your quality of life, and then you're ignorant to the fact that if I didn't have this problem, how much better would I feel? They underestimate the benefit of not having it, if that makes sense.
Well,
So
I got to tell you, with me, James,
the treatment.
With me, there was two things I've told you on the show before. One is I fell asleep in a class, and it was so embarrassing because I was snoring, but to have a teacher wake me up, that was one. But the big thing was I found myself falling asleep during the day while driving. That was it for me.
You're probably like this guy right here. So this is the last patient I'll go over real quick. And I mean, look at this 500 minutes of recording time. He's having 90 obstructions an hour. I mean, like literally,
wow.
This guy is only breathing when his brain is not asleep. That's how bad it is. And his oxygen is in the 50s. Wow. Crazy sick. I mean, look at this graph. Now my question is, how does this guy even function?
Yeah, I mean, really.
How is this guy waiting to come in? I mean, I understand the guy who's got 10 an hour or 15 per hour, but how does the guy who's got 90 per hour not getting evaluated for years? It's mind-boggling. Doesn't matter if he's on his side, doesn't matter if he's on his back. And if you look at his tracings, which is
Wow,
here,
look at that.
and we go to his actual breathing, I mean, just check this out. I mean, like he literally lives 2 to 4 breaths at a time. He takes 1, 2, 3, 4 breaths, and then no breathing. Then he takes 2 breaths, and then he's out again. Then he takes 2 breaths, and then he's out again. Then he takes 4 breaths, and he can't breathe. Then he takes 3 breaths, and he can't breathe. I mean, he's living his life literally 3 to 4 breaths at a time. It's just phenomenal. And
I apologize to all the people listening on radio or iHeart or Spotify right now who can't see this, but James is doing a great job explaining it. Wow, this guy really has trouble, James.
yeah, but like, you know what I mean? You're like, how are you waiting? Like, how did you not get this? Didn't happen overnight. It's not like you wake up one day,
I know.
and have this problem. This problem is brewing for.
Was he married?
Is he married?
Was he married?
I have to look it up. I don't even know.
You know, I always wonder about the other
people. I assume most people are married. I guess I probably shouldn't assume that, but I do that most. Let me get rid of this now. I think we're done with this. Okay.
Yeah, because I
got one more.
If you snore, your wife or your husband do not want to sleep in the same bed with you.
Right. No, yeah. I mean, not if you're loud. I mean, just if you're restless, it drives people nuts. Just because you got to realize every time that person fixes their airway, you move, because the way you open your airway is you have an arousal. Well, when you have an arousal, it's not like just your tongue moves or just your, throat dilates. You know what I mean? Every muscle in your body increases tone. So that's why people that suffer from sleep apnea move around a lot. And that's why I tell people that if you really want to know how crappy your sleep is, just use your iPhone if you have an iPhone, or download an app if you have an Android, and do a time-lapse photography with your phone of your night in bed, and you just see yourself all over the place,
Here's a text from Sugarland. They want to know, does restless leg have anything to do with sleep apnea? I notice I'm real restless at night.
Well, restless leg is a condition that occurs when you're awake, and then so it's not related to sleep apnea. There's something called periodic limb movement disorder, which can occur when you're sleeping, which is where you move your foot in a rhythmic way. But that's also not related to sleep apnea. But you can move your legs around when you have sleep apnea, and then people think that's what it is. So,
James, will you explain to people that probably nervous about coming in, would you explain to them the first steps? They come in, they think I don't know, do they even admit they have a problem or not? I didn't, and someone said you're snoring. I would say, no, I'm not.
Yeah, I think people, there's different, some people come in and are ready to just like, they're done. They just want to get whatever it is. They kind of know. They read on the internet, they Google, it looks like a duck, it walks like a duck, it sounds like a duck, I'm a duck. And so, and I think that's important to have an open mind and not be not like just the way you talk about air pressure and you're positive about it.
Mm-hmm.
You need to have an open mind when you're trying to treat this problem, because there are a lot of treatments and a lot of them work well, but there's no perfect treatment, and every treatment's going to have a good and a bad thing about it. There's no treatment that's all good and no bad. Like even your CPAP machine, I know you love it, but there's a bad side to it. It's not all good. It's good for you and you've accepted it, but you still got to carry a machine around when you travel, and you still got to use it, take care of it, and you can't just hop in bed. So there's going to be a negative. So like any other treatment, like diabetes, you have to just weigh the pain in the butt of doing it, or the acceptance that you have it. Look at, you have diabetes, you gotta prick your finger, you gotta wear a monitor, you gotta get drugs, you gotta take pills, you gotta take insulin shots or whatever. The sooner you accept it and stop, being so angry about it, the happier you're going to be and the better you're going to feel. So I think in any chronic condition, people go through that and they handle it in different ways. And some people are more accepting and some are not as accepting. What I like about the fact that I do all these treatments and have all these options is I can have a really educational, informative, realistic conversation with each person because about the different choices, because I actually do the different choices. I don't just know about the different choices, I actually do them. And one of the things I was going to share with you was I had a patient came in. I always, if I have interesting cases, I like to bring them up. And I had for interesting patients, not cases. And this guy was diagnosed with sleep apnea like in 2000, I want to say like 10 years ago. Okay. And then he tried air pressure and he kind of, did use it, didn't use it, did use it, didn't use it, and then gave up on it. And then several years later, he went back and Inspire was out. He went in and he said, I don't want to use a CPAP machine. And they immediately like drove him, like kind of directed him to an Inspire implant. So I think 2 to 3 years ago, he got an Inspire implant put in, which is it's a pulse modulator that is implanted into above your pec on your right chest, under your skin. And then there's an electrode that goes to your tongue nerve that they wrap around the motor nerve to your tongue. And then there's an electrode, that sensor that senses when you're trying to breathe in. And then when you activate the device with the remote, so during the day, of course, it's not on, but at night when you're trying to sleep or you're sleeping, you turn on when you go to bed. And then when it senses that you're not able to breathe, you're struggling, it shocks your tongue with a bolt of electricity, and then your tongue moves forward. So your tongue's moving forward, 12 to 14 times a minute, because you breathe 12 to 14 times a minute all night long. And then you wake up and you turn it off. So this guy he got the implant and then he couldn't do it. He couldn't tolerate it. He didn't like it. It hurt his, it gave him discomfort when they tried to shock his tongue. And so, anyway, so now he's been walking around with this Inspire implant for over 2 years. He's got a wide scar in his chest. And, he's the kind of, he works out, he's kind of a husky guy. And it's interesting. When I talked to him, nobody offered him anything else. No one offered him an oral appliance. In his sleep study that we did, he was having roughly 40 obstructions per hour. And with this piece of plastic, which is really what it is, as oral appliance, he's having 6 per hour just by wearing a little tiny, yeah. So that's like a home run therapy. He had no risk to him. He didn't have to have more operations. I mean, he wants me to take the Inspire out of him, is what he wants me to do, because he doesn't want to walk around with this pacemaker in his chest, essentially. So, but that he wasn't even offered another option is, concerning and disheartening, because that's the point, is you're going to make decisions based on the information you have. So you want to have all the information so that you can make decisions for yourself, So that's what I try to do. I try to give people the facts so they can decide what, hey, what's the harm in this, or what's the benefit? What's the harm in that? What's the benefit? So back to your question, when people come in, there's different types, some who know they have it and are just there to face the music. And then there's others who don't want to be there, but their wife's making them go. And, I kind of handle each patient a little differently, because I don't want to turn them off.
They've got to do the sleep test, though, right? Before you can really do anything.
Yeah, and they're willing to do it because it's so easy. I mean, it's like $100 test or $125 or $150. I mean, it's not like it's $1,000. So they have there's no monetary reason to excuse. It's not like it's expensive. Right. So, and then they do it at home, so there's no inconvenience excuse. So they really have no excuse to not do it. So they do it, and I will say 95%. I would say 99% of my patients, after they meet with me and I show them what is going on with them, and then we also do an airway exam and an ENT exam and make sure their nose is working well for them. 99% of patients do something. No one does nothing. And it's just because I spend a lot. I spend easily 30 to 45 minutes, sometimes an hour, with one new sleep patient, especially if they have sinus and allergy problems. And that's the hand holding that most people don't get. They get in and out, they get the test, they get the result. The results, they're told they need a CPAP machine. That's about the visit. Oh, your test is positive, or it's over the phone. Yeah, we got your test result, it's positive, go get a CPAP machine. Come back in a month, We'll send the order to the DME company. I mean, if you look at how people are being treated, I mean literally treated like a person, not just treated as in medicine, but treated. If you look at how they're treated, it's no wonder that there's such an overall low success rate. You know what I mean?
Yeah. So once you determine now they have sleep apnea, then you discuss all the different options.
Right.
Like like CPAP machine or
Well, first,
whatever.
like if you have
That's
a
when
bad
you
nose,
discuss
talk
the
about
options.
if they have a bad nose, sometimes making your nose work a lot better if your nose is terrible. You may even know it's that bad. You may just live with that too. You can sometimes cure mild sleep apnea with nasal surgery, and I like nasal surgery because it works. It's like basically 100%. If you're not breathing well through your nose after your surgery, you will be breathing better through your nose. It's not a maybe. You can't really say that about sleep surgery. You can't say in sleep surgery after we cut on your throat, you're not going to have sleep apnea, or you're going to have less sleep apnea. You should have less sleep apnea, but it's not like a guarantee. And then
Gotcha.
we talk about oral appliances. And then the nice thing is when we do my exam is I show them if their airway improves when their jaw moves, so they know that they're getting a physical benefit from jaw movement to help them make their decision. So that's the discussion we have based on the severity of their problem. And then of course money comes into play because if your CPAP machine is going to cost you $100 with your benefits and your oral appliance is going to cost you $1,500 with your benefits, that may affect your choice. You
Right.
may choose the one that costs you $100, and even though maybe that's not the best choice for you, but the risk is $100, so people will take that chance. You follow me?
So I've told you before, I'm on a BiPAP machine.
Yeah.
We talk about CPAP. What's the difference?
They're both positive air pressure. Actually, now the boxes. It used to be the box for a BiPAP was a lot bigger than the box for a CPAP, but now they're
Oh,
basically they look. Yeah, when you get a BiPAP, it's like this big old thing. I mean, like you're taking home a ventilator. But now they're both like a shoebox or smaller. And really the difference is in the electronics. A BiPAP, we're able to control the pressure that we deliver while you breathe in and the pressure that it provides as you exhale. In a CPAP, we can only control the pressure that you get while you breathe in. And most people don't need what you have, fortunately. Bilevels are more expensive, so that's why we don't want to give it. I mean, you could give a bilevel to everyone, but they're just more expensive and not necessary, so we don't.
well, I'm going
But
to tell everybody
fundamentally,
I'm on Medicare, and Medicare pays for everything.
yeah, as long as you prove you're using it, which you do, so that's not a problem.
Yes.
Yeah,
Yeah. And
and
it is now, do they have to come back? Let's say you put them on a CPAP machine. Do
yeah,
you have
so
them come back again?
of course, yeah. The cool thing about in the last several years, the reason we don't go to lab much anymore is the machines automatically are able to figure out the treatment pressure that someone needs. So you just send them home with some parameters in the machine, and the machine basically adjusts the pressure while the patient sleeps automatically, and then it records everything you're doing when you use it, when it's on, when it's off, if it has too big of a leak, if you're obstructing while you're wearing it. And then when the patient comes back, we can generate a report that lets us look at that, so I can help them find the best therapeutic pressure for them. And I see people as many times. Some people need more cheerleading, some people need less. So it just depends how they're doing, how often I see them. But in general, I see them at 1 week and then maybe a month if they're doing well. And then it's basically annually after that. So unless your weight changes a lot in either direction, you don't really need. I have people come in like, oh, I had my last sleep study was 5 years ago, and my doctor said I should get another one. But nothing about them's changed. Their health history hasn't changed, or their
Right.
weight hasn't changed. So I don't get another sleep study because they don't need one. They don't need one because it isn't going to go away magically. And if they're treated, then we're going to know they're effectively treated because their device is going to record their treatment every night, their efficacy. So what's most important is to look at the device, the data from it, um, and it'll tell you if you're being effectively treated. And if you give an oral appliance, which doesn't record how well you breathe while you wear it, then what we do in that case is we have you do a home sleep test while you wear your appliance. So that's how we're able to know how well the appliance is working for you objectively. And actually have an example of that guy. I have all his stuff if you guys want to look at it. But oral appliances can be extremely effective for some people. The trick is finding those some people.
It's been so long since I've had mine. I don't remember how I decided the nasal versus the whole mask. I
Yeah,
use the nasal. How
yeah.
do you, what do you do? Do you,
Well, a
Do
lot
you
of
give your
people that
patients both of them to see what they like best?
no, no. I mean, so one mistake that people do that don't come who get fitted or dispensed by people who don't know what they're doing is they'll ask the patient, "Well, do you breathe?" You know, the patient will be like, "Oh, I'm a mouth breather. When I sleep, I'm a mouth breather." Like, "Oh, you're a mouth breather. You need a full face." That's what they'll say. But you're people with all everyone who has untreated sleep apnea is a mouth breather because I just showed you they're dying.
Right,
They're all
right,
gasping for air. They're all trying to breathe. So that's why they're mouth breathing. So just because you're a mouth breather when you're sleeping doesn't mean that you can't effectively have air delivered through your nasal cavity to your throat, right? And we're all mammals are designed to breathe through their nose. Our nose is a special. It's different than our mouth. Nobody I know, I've never met anyone in my entire life who wants to be an obligate mouth breather. Everyone wants to be an obligate nasal breather, which I mean is everyone wants to breathe through their nose. Nobody wants to walk
right.
around breathing through their mouth. I mean, it's because it's not comfortable to breathe through your mouth. And it just like it's not comfortable to breathe through your mouth just when you're walking around, it's also not as comfortable to have air pushed through your mouth. So ideally, we would rather have you on a nasal mask. And the nice thing that I'm an ENT is that if you have a nasal obstruction problem, we're going to find it on day one and fix it or address it or medically manage it or whatever you need. So you're not these people I see who are given CPAP machines who have bad nasal anatomy or bad nasal allergies or bad sinus problems, and no one even looked at those things. They just put them on the machine. You know, it's like they're so unidimensional. They're like horses with blinders on. They're not looking at the whole picture. I've seen people come to me with sleep apnea with kissing tonsils in their throat. It's like you're trying to tell me, and they weren't even told to get them removed. It's like they got a CPAP machine. It's like it's so auto. It's just like auto. It's like autopilot. Positive sleep study, get a CPAP machine. You know, and there's no thought in between. And sometimes that's all you need, but there are a lot of times you need other things done, or at least evaluated.
We just got a text from San Antonio. First of all, they want to know, do you treat thrust?
Hmm?
Do you treat thrust?
You mean thrush?
Maybe they spelt it wrong.
I don't know what they mean by thrust.
Okay.
I don't know what that means. I'm sorry. Do I
What
treat
about
thrust?
what about name brands? Which one do you suggest for CPAP?
Well, it used to be Philips and ResMed were the two best. Well, the two biggest, manufacturers of air pressure. But when Philips, basically, they had a big recall and they weren't there.
Yes, I remember that.
They're still not allowed to sell units, so that allowed a lot of other companies to come into the market. So we use one called React, which works really well. We've had good luck with. ResMed is clearly the number one biggest market cap, biggest device company there is. Those are the two main ones, but there are other smaller, brands out there. So these things are basically fans. And I don't know the last time you had to buy another fan, but I think you buy one fan and it pretty much lasts you your whole life. So these devices do last a very long time. They don't break.
Yes. The only thing I ever replaced maybe is a hose.
Yeah, the hose, the filters, but I mean the actual blower and the humidifier. The humidifier is a plastic bucket, that you put water in. It's like a Tupperware. And then there's a heating element underneath it. So again, when's the last time you had to change your stove heating element? I mean, these
Right.
these things don't break. They last a very long time, fortunately.
And her third or fourth question is, do you have to put water in your CPAP machine for the humidifier?
Humidification is a comfort feature. It's not a treatment feature. So if you if you like the humidification, then you should do it. And if you don't, then you don't have to. It's less work for you if you don't, because you don't have to worry about using distilled water and cleaning
Right,
the
right. Yes, yes.
fur and all that. So
And how often should you clean your machine?
well, I tell my patients, once or twice a week, once a week, to run like vinegar water, peroxide water through their hose. Like once a week, take your mask and clean it with Dawn. The silicone part, wash your headgear. Your humidity chamber once a week. Just take it like where you do your dishes and just wash it out and let it dry so it gets totally dry, so it's not always wet. And I really do think that's plenty. And I don't recommend those special UV or whatever other scare tactic, sales marketing thing that those guys do to get people to buy those for their machines. Nobody's getting pneumonia from CPAP machines. No one's getting, deathly ill because their CPAP machine. That's just a gimmick. I mean, I used to work at Ben Taub, Steve. I mean, these guys were homeless that had CPAP machines come in and you'd open the bag and cockroaches would come out of the bag and
Oh my God.
they're still using their CPAP machine. So, I mean, it's all about perspective. It's all relative.
So personally, I see ads for Inspire all the time.
Yeah, they're really pushing that.
Are they really good?
Well, so you had mentioned what else do we talk about in the office when I evaluate someone who has sleep apnea. So if someone who does have obstructive sleep apnea, one option they have is if when you do sleep testing, like the test I just showed you at the beginning of the show, or even during an office exam, we don't see sleep apnea occurring. We don't see the anatomy. The test is testing airflow. It doesn't know why there's no flow. It just knows there's no flow.
Right.
Like if your sink doesn't drain, you just know your sink doesn't drain. You don't know where the clog is. You follow me? And
yes,
I equate like Drano to CPAP. If your sink doesn't drain, you pour Drano in the sink, it magically drains. You don't really care where the problem was as long as your sink drains. And that's the nice thing about air pressure therapy is it doesn't matter where your obstruction is because the air pressure is going to dilate it and keep it open. So you don't really care. I'm sure, Steve, you don't really care if it's your tongue, your sidewall, your all you care about is if you breathe or don't breathe while you wear your device. So, but the problem is that if you want to have an operation, you want to go in there and fix, i.e. cure your sleep apnea outside of weight loss or things like that can be helpful. But if you need to do an anatomic correction or you need to fix the problem. So you can either fix the anatomy, which is like palate surgery, tonsil surgery, tongue-based procedures, hyoid suspensions, things like that. Or you can try to fix the physiology, which is what, or at least address it from a physiologic side, which is what Inspire is. So Inspire is neuromodulation. It's moving your tongue when you breathe in, when you take a breath. It's moving your tongue forward. And it also can help the soft palate. And so in order to qualify for an Inspire or to qualify for any sleep surgical procedure, you have to do an exam called a sleep endoscopy, which is where we look at your airway while you're in a chemically induced sleep state. And then we can watch you have obstructive events, and then we can understand why you have sleep apnea. And then you would know what operations are available to help address the things that we see. Is that so? So a sleep endoscopy, or a DISE, which stands for drug-induced sleep endoscopy, is the examination of the airway when you're unconscious to observe obstruction so you know anatomically where you're having sleep apnea, what's causing the sleep apnea. Then once you have that, then that's how we determine what options you have surgically, whether it's neuromodulation, palatal procedures, tonsillectomy, whatever, tongue procedures, whatever, this airway stuff. And the good and bad thing about those procedures, I mean, if you have sleep apnea and it's bad and you can't use an air pressure machine and an oral appliance isn't helping enough, I mean, it's like having cancer. You don't want an operation, but you got to have one sometimes. So that's the purpose of these options, and Inspire can be a great option for the right person. And the thing about these, procedures is they make you a lot better, hopefully, but they don't often cure, but they make you a lot better. And a lot better is a lot better. So it's better than nothing. And the problem is patients want to guarantee, like, oh, if I do this operation, I won't have sleep apnea. Or if I do this operation, I won't have this much sleep apnea. But we can't give you the guarantee. So it's hard to sign up. Now, if you find someone who gives you a guarantee, then I recommend they sign $1 million contract and you have them sign it So if you don't get the result they promise you, you get your $1 million, and they won't sign that deal because nobody can. They make it sound like it's a like a given outcome, but
Right.
if you do enough sleep surgery, you realize that it's not a given outcome. It's most people honestly get better, but the degree of which they get improvement is variable.
Well, without guaranteeing anything, how do you get someone to do
Right,
this surgery?
right. Because again, it's kind of like this. It's like you're going to die without your bypass surgery. No one's going to guarantee you're going to make it through bypass surgery. I mean,
Right.
it's a risk reward. So if you feel bad enough, you'll take the risk. So that's why a lot of people with mild problem, they don't, get surgery because they're not bad
Right.
enough yet.
Right.
They're willing to take the risk, And the people I see a lot of people who have, not a lot, I see a fair number of people who had sleep surgery and they were told it was going to be a walk in the park and it was going to work and it didn't work, and that's why they're in my office. So
Wow.
maybe I'm too
What
honest,
do
or
you do
maybe
for those people
well, usually
if
they
that
didn't have
didn't
good.
work? What do you?
Well, yeah, we start over, I mean,
Oh,
just because they had a surgery doesn't mean they had a good surgery. I mean, surgery isn't surgery, and painting isn't painting, and plumbers aren't plumbers, and trim carpenters aren't trim carpenters. So
right.
just because you had something done doesn't mean it was done what should have been done or could have been done or whatever you want to say. That's a
Hey,
different problem.
James,
But
what happens health-wise if someone does not take care of their sleep apnea?
well, short term, you live with the consequences day to day of fragmented, poor quality sleep, which is just poor sleep. So I think everyone has their own definition of what that does.
Right.
And then long term, it's just, it's taxing if the people who could see those tracings, if your heart rate is going from 50 to 100 down to 60 up to 95, then down to 50 and then up to 100. I mean, if you're doing that over and over again, meanwhile your oxygen's, 95% saturation, then you're down to 72%, then you're back to 80, then 90, then I mean, it doesn't take a genius to understand that all of that stress and instability of your cardiovascular system over time is going to harm your cardiovascular system. It's just like the smoking the cigarette analogy, Any one cigarette isn't going to kill you, but it's just the one after another, day after, and in the case of sleep apnea, night after night after night, it will add up to something bad. It's not if, it's just when. So, but because it's so infinitesimally small, it's hard. People don't appreciate that it's happening to them, So that's the problem. I wish it was more, like sudden. Like one
Right.
day one day you develop severe sleep apnea, you wake up, because then you would realize right away, like, wow, I feel like crap. I didn't, I didn't feel like, but and then people come right in, they wouldn't be waiting. But
Exactly.
when it develops infinitesimally worse, I should say in infinitesimally small increments over a long period of time, people get used to feeling however they feel. I mean, just like, someone who's 300 pounds, I mean, they walk around with 300 pounds every day. They forgot what it's like to walk around with 200 pounds. To
Right.
them, walking
Yeah.
around with 300 pounds is normal, but I guarantee you, if they could shed 100 pounds, they would feel like $1 million.
Yeah.
Yeah. And that's
Hey,
why
tell people how they can reach your office.
I mean, really, I think the best way is to go on our website, because we have, online forms. And plus I have a really nice, I kind of set up my website like you're shopping for a TV. It just, like most people know what they're looking for or what they have. It just like, this is what we offer. This is what's available. This is what it's like to have that done, or this is if it's covered, not covered. And it's just some before after pictures and some, short videos and
Nice.
things, like quick education, without weeding through a lot of, like you don't want to become a doctor on my website. You just want to know what you can do or what's available. So that's kind of how it's designed, and it's broken into 3 parts. I have a general ENT section, but mainly it's allergy, sinus, and sleep. You click on the button, whichever one you're kind of interested in, and then there's going to be the things. Hey, this is what we do to treat it. This is what we do to evaluate it. And in 5 minutes, you probably can learn more in 5 minutes on my website than you can Googling all day long, because I get right to the point, kind of like I am on your show. I just get right to the point, and not beat around the bush.
Listen,
So it's purelyandent.com. Yeah.
You've already got a fan club. We've gotten 3 texts, people wanting you on your next show to talk about all the different areas of ear, nose, and throat that you cover.
Oh, well, yeah. I mean, I
They
cover
want to
this.
hear
I
about
cover,
everything you do.
I cover,
Well, no,
right?
people
Yeah,
like you. They like the
I
way you
want to learn about
explain
it.
things. Yeah. So
Yeah, thank you.
give everybody your website again, because we got all these people listening on radio and on
Yeah,
iHeart.
it's easy because I'm in Sugar Land, Texas, and it's sugarlandent.com. So somehow I got that even in 2020. Someone didn't take that website name before 2020. I'm surprised. But yeah, sugarlandent.com. And I hope you like dogs. I own 2 Australian Labradoodles, and usually one of them will accompany you on your visit. And if you don't like dogs, then we'll take them out. But I would say 99% of the patients really enjoy
I would
rodeo
think.
or cowboy in their exam room. They're super gentle, sweet dogs. So, in fact, when they come back, they're upset that they're not there that day to
Wow.
keep them company. So we have a small practice. I have 3 wonderful. I really do have a good group of guys. I have 2 military, ex-military employees, a father and daughter. And one, his name is Tim, and his daughter is Elizabeth. Super sweet, honest. I mean, whole, good-hearted people. And then we have Giselle in the front, who's just completed her medical assisting education and eager to learn and help. So it's not a hustle bustle. It's not a Methodist. It's not 25 doctors. There aren't 100 people in the waiting room. I built my office for my patients. It's got big windows. It's a nice place to spend, an hour or 45 minutes or whatever you have. And I'm not there to tell you what to do. I'm there to give you good information and help you choose the best thing for you. Whether you do it or don't do it, just get educated at the
How
minimum.
about
So that's what.
how about bringing one of the dogs on the next show?
Oh yeah, well, you didn't hear him barking, or they don't
I'd
bark
love
at
that.
all. But
We got to get out of here, but James will be back again with us next month. James, you're the best, bro.
appreciate you.
Have a good. Bye-bye.
All right, thank
That's
you.
Dr. James Ludwig, incredible ear, nose, and throat doctor. People just love him. That's going to do it for us today. Thank you, Juan. We'll see you guys next week with more Ask the Experts.